Welcome everyone. We're about to kick off our second Confluence discussion this evening, and the topic is the future of healthcare. We're going to talk a bit about the medical mile and a bit about where healthcare is, what we think some of the challenges are, what some of the opportunities are. And we've got two really esteemed guests. I've had the privilege of working with both of them, and both are outstanding. I think you've got Dr. Callahan here from the Van Andel Institute and Dr. Elmouchi from Spectrum Health. I'm sure they don't need much of an introduction, but maybe Daryl, you guys can just give a brief background of who you are.
Sure, thanks, Patrick. My name is Callahan. I have the pleasure of serving as the Chief Strategic Officer for the Van Andel Institute. Have been at the Institute in some capacity since 2004. Part of my role there is business development. We've had several spin-out companies that we started out of the Institute. Nowadays, I work primarily with the research side of the house, helping them kind of get the organization behind the amazing growth we've had over the past several years. And so that's what I've been doing for that since 2004.
And Jerry's wife is also the president of the Forest Hill School System board, so if you have any complaints, you can direct them towards Jerry.
Just what I want.
He'll take them for me. Daryl?
Sure. So my name is Daryl Omushi. I am the president of Spectrum Health West Michigan, which has a little acronym in front of it that I'm happy to talk about as well, the VHSH. But I am actually I was a practicing what's called clinical cardiac electrophysiologist, so a heart doctor that specialized in heart rhythm disorders, and over many years kind of evolved my thinking and my focus and many roles with Spectrum Health, and now serve as the leader of kind of our West Michigan healthcare delivery, so our hospitals, our medical group, our continuing care, and also serve on the system leadership team of VHSH, our new combined organization with Beaumont Health, which will absolutely have a new name sometime in the coming months. But in the meantime, we have a horrible acronym to go by.
If anyone has a consultancy and would like to take the fees of naming that, they're happy to do so. Let's start out with a couple questions on the medical mile. So Jerry and Daryl, obviously the medical mile has built great institutions, great buildings, great energy down here. But if you had a magic wand and you could wave it tomorrow, what do you think we're missing? What would you want to add to the medical mile?
Go ahead first.
Sure. I'm going to actually take something, be very simple about this, because I've thought about this a bit in the past. So clearly we have Michigan State, we have an amazing medical school, we have all the new innovation going on down the street and all the building, the research labs, and Andel, an incredible research institute, and we have our Spectrum Health hospitals and our clinics, so you have an amazing clinical presence. You have all these great things. What they probably need is more connectivity. And we've worked on that over time, and I'm going to say some very simple things. So if anyone was at the prior talk, there was some discussion about what's going to happen with Grand Rapids and all this build-up. We're going to have affordable housing. Well, to get more researchers and folks that are going to do this work, we need to make sure we have accessible, affordable housing nearby. To be able to actually collaborate, we need to have collaboration spaces. It has to be easy. Believe it or not, when we have meetings in the middle of the winter down at the research lab, people get in their cars and drive down the medical mile, drive up the medical mile. Spectrum Health, BHSH, we're building a new, what we call our Center for Transformation Innovation, just down the way, North Monroe. That's not going to be easy to get to in the winter. So we all live in a climate that's tough. We need ways for us all to connect. So I'd love to see, in a dream world, some kind of better system, either walkways, covered walkways, a tram, something that makes it easier for us to collaborate and connect, something as simple as a coffee shop and then affordable housing for everyone to live. I think we'd have a whole lot more togetherness.
Exciting. That's great. So I'll have Jerry.
For me, I'm on top of that. Daryl's not.
He can say something
You're
far
not
more
you're not meeting next time. The two things I would say, one overlaps with yours. The first one was, and I've said this for years, more leadership in the areas that we don't have that we're going into, right? It's always the leaders who have successfully done it in other places and have the experience of doing it. We want them in our community. We need them in our community. We need to recruit them, and we're doing a great job of recruiting to Spectrum. Great job to MSU, the Van Andel Institute, Mercy. We're doing a great job of recruiting, but we need to continue to do that and really intentionally think about the areas that we need the special experience that we don't yet have. And in the earlier talk, they talked about intentionality, and we're pretty good about being intentional. I still think we need to think about where the next two steps are and start fostering those relationships to bring those people there. That being said, the thing that scares me the most, and where we overlap, and the gentleman before talked about it, is it's going to drive property values up and such. I mean, we have an underserved population that I don't know how, I can't think of a great way right now how to bring the resources to them and have them participate in this vibrant growth that we have. I sit on the Smart Zone board with Jeremiah was here earlier. On the Smart Zone board, and that's a high-tech, high-growth investment fund that from tax abatements that we can give, but it's for high-tech, high-growth, and we don't see enough opportunity coming through from underserved populations where we can fund it, and we need to figure out a better way to close that gap, not just here in Grand Rapids, but everywhere.
Okay. So the medical mile has continued to grow with institutions that have always kind of been a part of the fabric of West Michigan, right? I mean, Van Andel with the DeVos Van Andel families, Amway, Michigan State, which has always had some type of presence here, and Spectrum, which has been here for over 100+ years. What do you think we need to do to attract new entities to the community, bring new ideas, new thinking, new capabilities to West Michigan, given we have this incredible medical mile? Darryl, why don't we start with you?
All right. The funding, everyone's going to tell you most people will tell you funding. The last group likely would have said we need more funding, we need more people funding ideas. And the funny thing about money is money follows great ideas. So money's fungible, and quite frankly, ideas are fungible. I mean, ideas don't all have to be born here. But if we have an infrastructure here, like I believe we have, that's innovative, creative, collaborative, like no other, and I really believe that's true, we can recruit ideas and we can recruit funding to have the impact we want to have the economic impact, to have the healthcare impact, to have the service impact, to do things that no other community can do. One great example, this goes back to 2006, that we did just as a case in point. We were the first community in the country to do a personalized medicine study on 300 patients, cancer patients in West Michigan, where we'd profile their tumors and run it across a database, look at the molecular attributes of their particular tumor, run it across a database of known drugs, and then provide that back to physicians. And that was paid for, the study was paid for by priority. So it was an insurance paid 300 patient study in West Michigan using that information. That would not have happened anyplace else. And this is 2006. I mean, now companies are doing it on a regular basis. No one was doing about that. Certainly no insurance payers were paying for it. And we just got people around the table and said, can we try this? And we did. And it was an excellent example of what we could, the kinds of things that we can do here.
Great, and I'm gonna back my way into this. So aside from the weather, and I'm gonna have to confess I'm from California, and so I struggle, except for I love late spring into fall. But if you take away the weather and you look at what do we have already? Well, we have a really great community to raise your kids. We have affordable housing, maybe not as affordable as it used to be, but far compared to cities across the coast and other parts of the country. We have amazing philanthropy and community focus in this city, in this area. We have, as we talked about before, these amazing medical complexes, research, academics, all on the street. So what are we missing? I think we don't do a good enough job telling our story outside of our geography. Jerry just gave a great example of something. We actually had Rady Children's Hospital is probably the national leader in genomics applied to care. It's in San Diego. We had their kind of head person here, about a month ago, and he came here because he knows, he's an expert, and he knows what we've done here, and we've been able to get the state to help fund a lot of this, and now every kid in the state of Michigan can get a whole genome sequence under certain conditions, and it's truly amazing, and they can't figure out how to do it in other parts of the country. He's an expert, he knows. We need more people to know our story, what we've done and what we have, and then I think we can attract a lot more. My concern is we always want to build more and more and more. We still have to celebrate what we have.
We have a lot of talk, and both of you discussed it already, on medicine and healthcare, life sciences, which is great. It's a great industry, but it's not the world's only industry. How would you leverage the medical mile to tell that story to attract other businesses to the community? Maybe businesses that are on the periphery of medicine, things like Google, who are looking to get into medicine, or I was speaking to somebody from Google last week. Anybody have an idea how many employees they have in the state of Michigan? Just curious, you want to take a guess?
It's a small number, I assume.
Like 3,500 employees in the state of Michigan.
Big center in Ann Arbor.
And about a dozen of them are in West Michigan. So why aren't we attracting that when you look at our capabilities, our infrastructure, all the things you just pointed out? Why aren't we attracting that in West Michigan? How do you think the Van Andels, the MSUs, the Spectrums, or what are we calling this, the BH it's going to take a little while, the VHSH, how do we leverage those assets to tell the story to attract these companies in your minds? Darryl?
Oh, okay, I'll take first. I'm going to go back to my last comments and say I think we're much more inclusive amongst ourselves and not necessarily spreading. We're very modest in West Michigan. We don't necessarily spread things as we should. We don't network as we should. I'll be honest with you from that, and I'm learning a whole lot more about Southeast Michigan now with our combining with Beaumont. One of the things that we miss out on here is we don't have as easy access to other parts of the country with our airport. And we've grown and we've done a lot, and there's a lot more flights, but you can't get to Google's headquarters with a direct flight from here, and that truly is a problem. So I think that there's a lot of focus on so many things. I think that ultimately is going to be one of the hinge points where if we can ultimately expand the airport in a way that's usable, even if there's periodic direct flights to these places, it'll be a lot easier for these companies to invest.
Fair enough. Jared?
Yeah, and I mean, building on that, and actually probably more importantly, the story part, right? We're just really, really bad at telling stories. Even when I was sitting up there listening to Anthony talk, and he was talking about the opportunity that that Banff has and the kinds of stuff it can go, and he started automatically going to other things it could do. It could do, potentially, ultimately, get to neuroscience. And my West Michigan part of me saying, oh, you can't say that yet. You can't say that yet. I got to tell you, in Silicon Valley, they were saying that 6 years ago, right? I mean, so we just don't do a really good job until we know we got it lined up, we got it locked down. And someone asked me the other day, the 4 spin-out companies that we had at the Institute, going back to 2006, we've sold 3 of them already and did well on them, and we have 1 more that we'll probably sell here in the coming years. And we've done very well, but none of that money came from any place else. That it was a good idea. We put money around it. We got it done. We got it launched, and we didn't tell anybody about it, right? And no one even knows that we did it, right? We didn't tell anybody. So we do a really good job of telling the story. And I don't know. It's not in me to know how to do that. I mean, everybody here seems to work in real time on what's happening today and what the future's going to bring, and don't take the time to lift their heads up and tell any story. So that's probably the one thing I would say. And those, as I said before, ideas are fungible. If you tell the story, they will come. I mean, I really believe they will come.
Fair enough. Any questions from the audience? I want to kind of keep this free flowing, and I don't really want to listen to myself that much. So
we want to
exactly. Any questions that you want to ask, and we certainly have others we can go through, but we can break it up a little bit. Yeah.
Yeah, my question, I guess, is really for all of you, but Darryl in particular, with the Beaumont merger, how do you see, obviously care delivery and operationalizing are, the bulk of that, but from an innovation perspective and the visionary aspect of all the things we've been talking about tonight, how do you see that sort of prioritizing going, or what's the vision for that collaboration?
Yeah, no, I think that's a great question. Right now we're in the messy, and I would like to say the messy middle, the messy beginning. When you bring 2 organizations together, big organizations, there's a lot to get through, and most of the initial work is all back office connection. With that said, and I give credit to our board, and I give credit to Tina, we're talking and looking at how can we be bold and what can we do differently. And this is going to sound very, I don't want to say unsexy, but I'll say unsexy for our state. Michigan, as a state for healthcare, is not necessarily innovative, not necessarily ahead. And the area that there's a lot of passion that we're trying to push forward, and I think we have a benefit to do that because we have a very large health plan, is to really push toward value-based care. And what do I mean by that? Well, I mean, it's funding and paying for things up front, so you're not paying for, I don't want someone to have to go see Anthony if we can do something early on that prevents that person from getting prostate cancer. There's so much more we can do, but that's not the way it's paid for in Michigan. We do have, believe it or not, even though our healthcare costs are high in the state, relative to the rest of the country, relatively low healthcare costs, but we don't pay for the right thing. So I think you'll see a lot of innovation there. I think with that, you'll also see a lot of innovation across state. Beaumont has some amazing clinicians, amazing areas of focus, and amazing historical research. We're already doing it. We have now joint tumor boards across the state. We're also good at virtual now. Isn't it great if you were to come here and you have someone across the state that can focus on your care and help? I think there's so much collaboration, and we could talk for 2 hours now. In the last 3 years, what we've done with MSU and collaboration. Actually, I have a stat here between MSU, Van Andel, and Spectrum Health since 2020, since January 1st, 2020, and a lot's gone on in those 2.5 years or so. There have been 1,800 research publications in peer-reviewed journals. 333 of those 1,800 have been some combination of the 3 of us. Some all 3, some 2, some us and Van Andel and MSU, so forth. But I think that NIDUS, I think we can expand that across the state now. I think we have a lot of connections on the other side of the state that we need to exploit. We're a good state, we're a special state. The other thing that we didn't talk about, I'm convinced, and you'll understand my focus on this, I think in 20 years, we'll probably have the most expensive real estate in the US because we'll have the best climate, we'll have fresh water. It'll come to be a better place to live than being underwater in Miami.
That happens in 20 years.
Maybe 40.
All right, maybe 40. Great.
You know, I'm not, mine's not healthcare. I can't answer it. I could give you maybe one example again, going back to what I think this community can do around healthcare that speaks to the other parts of the earlier conversation that people are having of what we are. We're a community. We don't look at the problems the same way. And inviting the patients to the healthcare conversation so they can help make decisions in real time. So it's not you know, I talk to my insurer talks to my doctor talks to, and really have a conversation. So that one example I gave before of that personalized medicine study, the two best of the 300 patients or people we served in that study, the two best examples I have of that whole study were people who didn't even take the service. It was two women, both in their 70s, both with metastatic late-stage breast cancer. Both were, how the study worked was prior to saying yes to the study, you had to sit down with an advanced care counselor. That was the only requirement. You had to sit down with an advanced care counselor who would say, listen, we want to try this for you, but understand this is, you know, a pretty bad disease in your bad situation. And it was the first time that anybody sat down with those patients and gave them the lay of the land. And both of their daughters who were sitting with them at the time said, Mom, we're going to do this. And the mom looked at the daughters and said, honey, I'm done. I'm okay, I'm done. This is great. I'm glad our community wants to do this. I'm done. If we have those conversations, and this community could actually do that. You'd never have that in Boston. It just wouldn't happen. So inviting everybody to the healthcare party, I think makes the cost of care better, the outcomes better, the you know, all those parts better.
The other questions? So one of the things that I've noticed, so I'm a Grand Rapidian by birth. I was born across the street, well, actually in East Grand Rapids, but in the entity. And one of the things I've noticed is that the companies here are the same companies I grew up with as a kid, right? So it's Amway, it's Meyer, it's Kellogg, it's all the same companies. And that's great, they're awesome companies. But at the same time, there's almost this, we keep everything in our own little worlds and we don't necessarily attract and bring maybe something bigger together. I kind of see the same thing happening on the medical mile. I mean, everyone has, you're connected, but you're still extremely distinct. How do you think you need to take the next step to bridge to some of these things that we could do better together? Although we've published a lot, where's the clinical application? Where's the same job hires that we're working on? Where are those things? So, Darryl, what do you think the Van Andel, Spectrum, MSU cadre of folks can do better?
Yeah, you know, I have to say, I think we've done a lot of good. I think there's way more opportunity than there is runway behind us of positives, though. I think there's so much we could do together. I think the challenge, and I'll just be honest, is it's one thing for two organizations to try to find ways to work together. It's another to take three. And, you know, Jerry and I have been there, and quite honestly, COVID probably curtailed our last effort for the three organizations to really come together more closely. With MSU, Spectrum Health has something that we call the Alliance. It was formed when the medical school came here, when the building was built. And it's actually, I would argue, one of my favorite parts of what I get to do in my job. And we essentially have $4 million a year that we fund for joint research, joint faculty appointments, and the amount of projects coming out of there that really are collaborative, that spurring grants. We now just got an RO1 grant. It's amazing, and I think that's great. I actually sat through, we have a research day with all of our residents and fellows who publish or did any type of research. It was at DeVos Place a little over a week ago. There were a couple hundred people there. It was great. And the keynote speaker at lunch was Dr. Matt Steensma. Matt is an orthopedic surgeon who specializes in what's called orthopedic oncology. He actually has a dual appointment at Van Andel and Spectrum Health. He is an excellent basic science researcher, and he's an amazing clinician. Grand Rapids is not a big enough city to have an orthopedic oncology program, and we would never have attracted Matt to come back to Grand Rapids if not for Van Andel and what's there. So I give you these as examples of pieces, but when Matt talked about doing research and being a clinician, and one of the things he said, which has stood true to me, he said, you know, for his first few years, he was beating his head against the wall because when he wanted to get a grant or do a study, not only did he have to work through whatever the NIH or the DoD or whatever granting agency was there, but he had to go through the Van Andel IRB, which is the Institutional Research Board. It's something that's very important when you do research. He had to go through the Spectrum IRB. Separate, distinct, different processes. And imagine if we had MSU, we'd have to go through the MSU IRB. So one of the things that we're just not good at I think corporate America is not terribly good at. I definitely would argue in healthcare we're probably awful at. And I think research institutions, just as their way, is we create processes that are very important and very good for the institution, but they're not necessarily built to be plug and play collaborative. And in my dream world, we find a way to do that better. We've had discussions, we've done some, we're just not there yet.
And Matt's great to talk because he's like got a central casting. He's got the 3 years going on. But when he did the IRB thing several years back, we did actually. I didn't know that we had 2 IRBs until Matt told me we had 2 IRBs, and I said, why can't we just depend on their IRB, the clinical IRB? And it was a fight and a half. I got it done. I'm like, this just makes no sense. So it took me 6 months to get it done, but we finally have. So now we depend on your IRB for all clinical stuff. But it's all those little things. Yeah. I remember here in this building on the top floor meeting with Norm when he just moved into town. I remember looking out the window where the expressway was going by on the side. I said, Norm, one of the things he goes, what can we do in this town? Same question you just asked. I said, Norm, what we can do in this town is everybody driving by in those cars all think everybody on the hill is working together as friends and colleagues and seamlessly, and we're not. We have to make them, what they believe, we have to make that true. That's the one thing we need to do. And there's a lot of, and it's not politics and it's not organizational structure. There's a lot of legislative, regulatory things that we all have to deal with, and because we're so different, because we can do things more collaboratively and are so different, I think that the hurdles are fairly high. But we could do that. We could absolutely do it in our community, but it's a lot of work.
Back to the audience, any questions that have sprung up for you like to ask? Hard for making my job right now.
You mentioned the legislative or regulatory environment. How can we do a better job of that? How can we work better with the state to make this more seamless? It feels like in healthcare, there's just a lot of bureaucracy. And then we have research if you have Michigan State. It does seem like it's more. We're making progress there. Is there something we should be doing different to make there less bureaucracy and all this move forward together?
The answer is yes, I hope. And it's not just state, it's also federal. A lot of stuff that we deal with in the Institute on the basic research side, it's all federal regulations and those kind of things. And the number of hoops you need to, we've grown since 2009, I think, 500% in our extramural funding from the federal government. That's great, that's fantastic. That's added in money to our community and do some great research. The problem is when you do that, you have a lot of obligations that comes with. A lot more obligations, a lot more oversight, a lot of other things we have to do. Then you have the state, the state regulations and the clinical regulations, and I don't have a good answer for it. We work at it every day to try to figure it out, but I don't know how we legislate or lobby to make some of those changes, because we're asking them to do things they're not made to do. They're made to protect what they're supposed to. There's good reasons those things are in place, but.
Well, I have a theory, and there's a great pie chart, graph type thing that everyone should look at if you're involved in healthcare at all, and it really applies to research, human subject research, and so much other research. If you take us in the middle and you look at every agency that is somehow regulating us, there's like 60 some. It's like a spaghetti chart of regulations, everything from CMS to the Office of Inspector General to the Nuclear Regulatory Agency and so forth. It is unbelievable. And quite honestly, if you look at each one of those agencies and each one of what they're tasked with, it's a good thing. You'd look at it and say, of course, I absolutely want the Nuclear Regulatory Agency to ensure that the isotopes that this organization uses and whatever they're doing are safe, handled well, and so forth. The problem is each one of those is a complete silo. So the Nuclear Regulatory Agency, this agency, and what ends up happening is many of their regulations not only overlap with one another, but conflict with one another. And so we end up spending, just within an institution, let alone cross-institution, thousands and thousands of man-hours and millions of dollars per annum to try to navigate. We have whole teams that help us do this. This is not to say that it's insurmountable, but to change it, that's a tough thing. to be able to find ways to work with it and not necessarily take no as an answer, I think is big. And quite honestly, the one thing I do hope, and maybe this will be something for the country, definitely within healthcare and research, I think there have been a ton and a billion negatives about COVID-19 and how it's impacted all of us in society. Some of the good, I think everyone learned. We learned how to be virtual. Well, that's pretty good because I think that's probably here to stay in many cases. We also learned that a lot of these regulations are silly and we have to start moving quicker and doing things, asking ourselves, is this the right thing to do? Okay, I'm going to do it. And we're going to find a way to get past this. And I think we have to keep some of that speed and some of the momentum, lest we fall back into the same traps we all were in.
One of the things, the medical mile, it continues to expand, right? Every time I drive down Michigan, I'm seeing some new building or somebody just, redesigned another piece of property. There's a lot of good that comes with that. Yeah, I think we all see the benefit. What do you think are some of the negative consequences of the growth of a Spectrum, the growth of a Andel, even a Michigan State? What do you guys think are some of the ups and downs of that size and that growth?
What we started talking about at the beginning, right? It's property values, it's the underserved population, it's the people that we have to bring along with us. The economic development people want to talk about the average salary on the Hill, right? We've had this many jobs, and this is how much salary they have. And those people are driving up the prices of everything, houses, food. All the things are going to continue to be driven, and we've got to keep a line of sight on it. What made this city this city, and what made us a great community is the community. And I fear that we, have that divide is not necessarily getting any smaller. The divide is getting bigger, and that animosity as a result of that is going to grow. And that's, that's the one thing that could really unblock this whole the growth. And I'd love to sit up here and say we have an answer. I don't have an answer, because one naturally drives, against the other one, and so the win here is a loss there, and I don't know how to make it a win-win. I'm not smart enough to figure that one out.
Yeah, I would echo that and say that if you look within Grand Rapids, you could look at by area code, I should say by zip code. You can see the life expectancy of one zip code, particularly the one that surrounds East Grand Rapids, is here, and the life expectancy of an adjacent zip code could be 20 years lower. As we start developing, building, adding all this here, you concentrate wealth and you concentrate resources, and you don't necessarily spread those opportunities around. As was discussed in the earlier talk, for those of you there, a very purposeful approach to all this has to address that up front. Otherwise, at the end, you're just trying to fix something that you've created. So I think that's one of the bigger issues. And then just to be very selfish, I'd say traffic patterns on Michigan Street. Michigan, it's challenging here, right? It is, and it's funny because I laugh because, as I mentioned, I'm from California, and I have patients. We're going to build a new $153 million outpatient tower that's going to focus on medical education, simulation, and have patient care right across the street from the Meyer Heart Center on Michigan. We're going to break ground in a few months, and one of the big questions we all said is, will patients want to come down here because they don't like to navigate traffic around here? I laugh because I think traffic is an extra 3 minutes compared to if I was in California, it'd be an hour to drive a mile. But it's still a real thing, and it's still very troublesome to folks. And now parking becomes more of a challenge. So there's a lot to tackle.
My obligatory ask, any questions in the group? No. All right. So,
you had one.
Oh, we do have one. Yeah.
And it has to do with health promotion and disease prevention. I wonder what percentage of research and effort are going into that.
This is the first part.
Health promotion and disease prevention.
Health promotion, disease
Keeping
prevention.
people healthy versus treating when they're sick. Is that fair?
That's great. For me, I can answer from the Andel Institute. None. Sadly, it is. We do basic research, right? Our folks get up in the morning to try to find, a protein that attributes something that unlocks something that's never been seen before and publishes that, and so that physicians like Matt can say, hey, listen, there might be an application, or people like Anthony Chang can say, if that's true, then this is true. So we don't do. At least at the Institute, I would say, if MSU were here, my guess is the answer would be completely different if it was MSU from their hospital or from their trainings.
And I could say, actually, I'll focus on one area in particular that I'm incredibly proud of. So at Spectrum Health, we have one of the largest culinary medicine programs actually in the country. We've been investing in this for years, and we've received state grants to study this, and we've shown that in young patients that have significant scarcity of food and don't have enough money to their families to get food. So they eat they're in food deserts, they eat all sorts of fast food and bad things. That if you give culinary medicine training to the family early on about how do you cook and find food that is affordable, that you can make that's healthy, you actually can improve outcomes over time. And we've shown all sorts of things with childhood obesity and otherwise. That's an area that I'm incredibly excited about. The other thing I can tell you is that every one of our trainees that comes through residency and fellowship touches culinary medicine. The goal would be when you go to your doctor and you start talking about a problem, they should consider food as medicine, something new and novel. Otherwise, something that I think is not necessarily research, but we've talked actually specifically with MSU about trying to find ways to study. When I mentioned earlier about value-based payment and value-based care, in the last year we've completely restructured our primary care, all of our clinics. We now have certain clinics that are dedicated to very high-risk patients that are older, that have multiple comorbidities, and their whole goal is to surround them with resources to prevent them from being in the hospital. You actually can prove that you spend a ton of money to do that, but you actually lower their overall disease burden, you lower their coming to the ER in the hospital, and you save money for the health insurance company and for the federal government if they're on Medicare. And so there are a lot of efforts like this. I would love to see more study of that so we can actually prove concepts and export them elsewhere. That's something we're just starting with the project, so we haven't done enough.
Any other questions?
I just wanted to ask, piggyback on that question a little bit. Any efforts that you are taking or initiatives on the behavioral healthcare piece of it and that preventative model with the same idea that if you are managing some mental health stuff that comes with disease or contributes to disease, that you reduce costs, reduce use of the medical system?
Well, first of all, ironically, I don't know there necessarily needs to be any further study on behavioral health problems, increased costs for healthcare, increased disease burden, decreased outcomes, decreased life expectancy. The answer is absolutely yes across the board. The biggest issue I think that we're definitely facing here in West Michigan and faced across the country, I would argue is two things. Number one, an absolute dearth of mental health providers and ability. We're actually really fortunate in West Michigan. You wouldn't believe this, but between Pine Rest, Spectrum Health, Forest View, Mercy St. Mary's, University of Michigan Healthwest, there actually are a fair amount of behavioral health providers, more so per capita than in most parts of the country, but still nowhere near enough. And so the issue is how do we embed those? How do we grow more? Virtual helps because you can scale this better, but there's just not enough people that go into it. And I'll be very honest with you, and the saddest part of this is that the way healthcare in the US is paid for, it's not paid for. It's paid for so minimally, behavioral health, that people can't go into it. We can't recruit people into it. We can't even pay for it. You can pay for it more in a value-based world. So I mentioned that clinic. We have behavioral health embedded in multiple primary care clinics when you're in a value-based model where you know, hey, Spectrum Health, we can invest in that and pay for it because we know it'll save money on the back end, but it doesn't pay enough up front. And quite honestly, it's always being looked at and getting cut, particularly in underserved populations, Medicaid and so forth. And my last comment, I'll get off my soapbox, it kills me to no end. You know, we had a gala, Spectrum Health, scheduled a couple days ago that we had to postpone, sadly. The whole goal of this gala was to generate funds for behavioral health, which we need now more than ever after COVID and now after all that's gone on in our community in the last 2 weeks as well. So great question. We have a lot to do.
Because, and one thing that, I mean, the value-based health, you keep on going back to it, and I can't agree with you more, because all the parts of value-based health, of keeping people as healthy as you can, as long as you can, you can afford to surround them with, to pay for, a mental health specialist or other people that can help them, or a dietitian, that you just can't. On a fee-for-service basis, we just can't get there from here. And until we go with something like that, I don't know if anybody in the country, not just West Michigan, we can really do that. We've got to get there.
Yeah, nobody gets paid for keeping people well, right?
Right.
Treating illness. So Gallup just today, released their analysis of the Americans' view on the U.S. healthcare system. They summed it up with a word chart. And you've seen those word charts where the most often used word is the largest on the chart. The three words that were most commonly used to describe the U.S. healthcare system were expensive, broken, and unfair. So those are the three words that came up most often. I know none of that resembles us in West Michigan, but what can we do in our backyard to not create the perception of being expensive, broken, and unfair? So,
Yeah, once again, I mean, I'm not in healthcare, I'm on the research side more than anything else, but getting back to not just value-based, I'm putting too much on it. I think that's critically important. I do think another thing that Daryl said a little while ago is really important too. There is a whole bunch of stuff in the healthcare system that in its day was maybe created for the right reason, but in practice, it actually just provides a cost and a barrier to make it more expensive, to restrict care for people who actually need it and deserve it. One thing that it's always been an issue in my head is, you mentioned millions of dollars you guys spend per annum. I'm tens of millions of dollars probably on HIPAA alone. I mean, just take Mike's time, of, how many times a day does he have to make sure he doesn't say, Mike's time, then his nurse's time, then the HIPAA time, then the lawyer's time. I mean, just that alone, those kinds of restrictions that we have just add so much cost to the system that can be redeployed to drive down the care and also maybe have more accessibility. I just think if we can rip some of those out, some of those really high cost, low value pieces out of the healthcare system, it addresses all three of those. Sure.
So I was just talking to a friend of mine who bought an old house, very old house, and the plan was to renovate it. And the more they looked at the house, the more they had the contractors come, they recognized it's going to actually cost more to renovate it than it would be to tear the house down and build a new house. I say this a little tongue-in-cheek, but I don't think any of us would have designed U.S. healthcare the way it is now if we could start from scratch. It is so complicated and so cumbersome. It is a huge challenge. Do I think that in West Michigan or on the medical mile that we can fundamentally change U.S. healthcare across the country? No. Do I think we could make inroads in areas that are important? And you mentioned, so expensive, absolutely. And absolutely, we're partially to blame. If you look up and down, all these things are incredibly expensive. Putting in fancy MRI scanners that we all want so we can get our MRI in a timely fashion, very expensive. Can we make it less? By taking out, we don't want to take away the MRI scanners. We don't want to take away the fact that if someone needs an important surgery, they're going to get it. What we ultimately need to do is take away all the non-value added parts around it. And quite honestly, this is a societal issue as well, and Jerry brought it up. If you look at U.S. healthcare expenditures, particularly on Medicare patients, someone else can remember the exact stat, but an overwhelming majority of dollars that are spent on a patient in Medicare are spent in the last 6 months of their life. And I will tell you, as a practicing doctor for many years, and I'm looking around and seeing others, I say, Mike, you pretty much know when an 89-year-old frail person comes in that has some underlying horrible heart disease or cancer, you're not going to make them live forever. You can make them comfortable, you can help them, but you're not putting another stent in or doing this is not going to necessarily truly improve their longevity or their quality of life. But in the U.S., we often do that, and it's hard to ask those societal questions. And we talked about it 10 years ago or so, and they became death penalties, just a discussion, and then it was dead. So I think there's going to have to be a wholesale change in how we approach things. And my concern is that there'll be such piecemeal approaches to it that where you save money here, someone will spend more money here, and there's so much lobbying and so much inertia, it's going to be a really hard thing to do.
Yeah, so on that line, last year, the AMA spent $67 million for lobbyist costs, more than the military spent on lobbyist costs in the U.S. The Commonwealth Fund also released last week their findings from 2020 that of the 100+ million working Americans, 51% of them with health insurance can't afford their health deductibles. How do we address the cost issue in healthcare, and how are we addressing it in the community? I don't know, Jerry, if you want to tackle that.
I'm going to say one part of that. You just used a perfect example. My mom, bless her soul, passed away earlier this year, and she had metastatic laryngeal cancer. She had been suffering with it for some time. And the end was fairly near, and she was in Chicago. She went to Rush for her last treatment. And in the end, the last 6 months are going to be the last 6 months. We can put them off for 2 years. That's great, but the last 6 months are going to be the last 6 months. And if they're the most expensive 6 months, that's a big deal. And the reason I bring the story up is we just got the bills back. She passed away, about 2 months ago. It was $500,000 for the last 2 weeks of her life. And had she known it was going to be $500,000, I assure you, she would not have taken any of the services. She would not have done it. She would have declined them and put $500,000 back in the system. And so having those conversations, you know, I mean, she's 89, she was 89, so she, you know, she absolutely would have said, I'm not gonna put, I'm not, we shouldn't do this, let's do, what else do you have for me to get me comfortable for the last 2 weeks, instead of $500,000, let's try this surgery, try that, and it's just, but you know, because she has great insurance, she had access, she took $500,000 out of the system that someone else could have used.
You know, you get what you pay for. And what I mean by that is once fee-for-service Medicare came about in the 60s, everything changed. And we have to find a way, I believe, it's all gonna follow where the money is. The payment model was wrong. I don't think anyone goes into healthcare, definitely doesn't go into medicine, doesn't go into research with grand designs that they're out to milk a system. I think the system sets it up where when someone gets a hip replacement, it pays a lot. And when someone has preventative care to talk about their obesity when they're 40 so they don't need the hip replacement when they're 55, no one pays for it. I firmly believe, and you can look at studies across the country, I'll use Kaiser as an example. We have a lot of components like that. Kaiser is a huge national system, I'm sure you're all aware. In California specifically, they have captive insurance. Essentially, all the people that go to their doctors and their hospitals have their insurance, about 95%. The rest of the country, Kaiser hasn't been able to recreate that model, actually isn't terribly innovative. But in California, that's where they were able to do this. And you can see that they actually do focus more on primary care prevention, and their overall costs are incrementally lower. I think the last study I saw 10 or 15% lower, and they're still able to make enough of profit to reinvest in those areas. I think that's a good example of a different payment model that works. The problem is it hasn't thus far been transportable for them anywhere else in the country, and there really is little incentive in most places to do that. So I firmly think the only way we're going to change is by ultimately stopping the massive increases and then starting to find ways to take out all of the waste, whether it's, and I don't want to comment waste there, but whether it's not having the right conversations with people at the right time, and not doing that extra MRI that someone absolutely doesn't need, or the stress test every year that someone comes in and demands. I think there's so much fundamentally to do. The question I think we'll all have is, can this be done incrementally in different areas? Can Kaiser do it there? Maybe can we do it here in the state of Michigan? I think we firmly believe over the next 5 to 10 years we can. It's slow. Or does this require statewide or federal government action? Time will tell.
So the Commonwealth Fund also notified that since 1977, there's been a 224% increase in the number of physicians in the United States. During that same period, there's been a 4,700% increase in healthcare administrators. What do we do about that? How would you address that? It seems to me that there's a C-suite person for everything in healthcare now. And as a former one of those, I think that's probably one of those. True. Yeah, I think that's probably true. So it is what it is. But how would you guys address that? Because it seems to me that we're getting further and further away from the patient-physician, patient-caregiver relationship, and we're throwing tons of layers into it. I know you mentioned administrative and legislative and regulatory, all those things earlier, but what do you think needs to be done? Because the project that they're speaking of is kind of pointing out we're creating unnecessary burden in work, and I'm curious what your perspectives are and how do we lessen that in our community?
This feels like it's for me, but I want to make sure you don't.
Yeah, go for it.
Regulatory. Just regulatory is all I'm going to say. You're up.
So I'm both. I'm a physician and administrator, so I'm somehow doubly burdened, I think. Yeah. I think I can tie it back to a couple things. First of all, we absolutely have the beginning of a physician shortage that will be tremendous over the next 10 to 15 years. And I will tell you, I have 3 kids and none of them are going into medicine. And when I was a kid, I knew I was going to go into medicine. I think that is going to be a problem. So whatever growth we've had, it hasn't necessarily been right. But I think the problem we have is we end up having a lot more specialists than we do primary care, and that is a challenge. When it comes to healthcare administrators, yes, healthcare has become so complex, and quite honestly, it's become a business that you have to manage to the point where there's been this growth of administrators. Could we have a system if there needs to be? Yes. We could, but you know what? You have to make everything around it simpler to make that happen. What came first, the chicken or the egg, the healthcare administration or the complexity? I don't know, but it's now all there. And I look at it, and we've been talking with our insurer. When you look at an insurance company, so there's something called a medical loss ratio. You may or may not be familiar. When you pay $1 to an insurance company, the insurance company spends a certain percentage of that dollar on your care. They pay it directly to the provider of care, to Spectrum Health, to St. Mary's, to an individual doctor, what have you, and the rest They have, for the majority of it, covers their administrative cost, and then there's a small percentage, depending on the insurer, that they use for profit to reinvest in themselves. And the medical loss ratios, if you look at Medicaid, where the government pays a fixed rate, and you look at the national insurers, the biggest ones, United, Centene, that are huge, that have tens of millions of people, the medical loss ratio on Medicaid for them is like 80%, which means that for every dollar that they're collecting from the federal government to pay to care for these patients, 20 cents of it is being held by the insurer, of which 15 cents of it is used for their administrative cost and 5 cents of it is used for their profit. That fundamentally just there alone, that's a problem. Then you come and give it to a provider like us, and we have probably, I would argue, somewhere in the 10-12% overall overhead to manage the care, and the rest goes to deliver that care. So what's that overhead? Well, we have to hire the 30 regulatory people in this one area to manage the regulations. We have to have security. We have to have IS. Our IS costs are hundreds of millions of dollars now just for cybersecurity and basic functions. And if we don't have those, what happens? You can look on Wall Street Journal last week, there was an article about all these small hospitals that shut down and had to tell people to drive 120 miles because they couldn't get their care because there were cybersecurity threats and they were shut down. I say this not an excuse, but just to say everything has become so complex. We have to find a way, at least where there's exchanges of dollars and information, to try to take away a lot of that complexity. So we're working, for instance, with Priority Health to try to take away numerous layers of complexity. We had prior authorizations, other things. Why should we spend dollars within our own system to do something that we should be able to do seamlessly? HIPAA, there's so many things. You can get me started. I'm with Roger. I think we can, as a system, incrementally do a lot, but I think this is going to require a whole lot more at a state and federal level to really cut it through.
So we're just about out of time. Any last questions? Yeah.
So I'm just curious if there's any potential negative impacts with the partnership with Beaumont. If you envision anything where maybe money gets funneled. I read some article last year.
Oh, yeah.
Just curious what your thoughts are on that.
Sure, fair question. So first of all, I will say a couple things. As we come together with another system, just like we did with Lakeland Health 4 years ago, our foundations are completely separate, and so all philanthropy stays local. So one of the concerns was philanthropy goes another way. The second is, will money be funneled over? We're investing, we have about $450 million worth of projects that just in the last 6 months we've approved for West Michigan, building that building, reinvesting in infrastructure, all sorts of other things that are absolutely needed. Beaumont will do the same, and the dollars will stay there. There are no plans, and I see no concerns about the dollars being spread across the state. Are there concerns about, well, how will this go, and could this cause negative impacts? Of course. Anytime you bring together organizations, anytime you do anything new, there's always a chance that you could mess it up, and I'm sure there'll be some things, bless you, that we won't do well. But I feel very confident with our approach and our plan, and we're really coming out and, give Tina credit. I don't know many other healthcare organizations in the country that have the word affordable in their vision statement. So everything is about being affordable, exceptional, and trying to simplify. And I give her credit, I give us credit that we at least I think have the right intentions of doing this well. I think it's going to be a hard slog for a couple of years just trying to figure out how to piece this together well that makes sense and not just be big for bigger's sake. The other thing I'll say, which, for that article, I think Priority Health is a crown jewel that people don't think about very much. Insurance isn't fun, insurance isn't sexy, but having a payer and a provider together is a big thing, and I think we can do good things together across the state.
I think we're out of time unless there's any last questions. Anybody? Bueller?
I
Yes,
just have to make
yes,
one
fair.
comment. Aren't these good sport jackets? We all kind of match and we didn't find out.
There you go. Yes, sir.
Yes, so thank you, everybody, for the participation on the panel. If we could find like a Goldilocks solution on the regulatory and the things that make it difficult, points of friction, is it your sense that there is sort of a shared mission statement among each of the institutions on the medical mile? And if so, kind of what are the pillars of those mission statement? What would that mission statement look like, I guess, if you could find the right balance between the regulatory burdens and things like that and the caregiving?
I'll go over that. So if you could start, if we could do the Goldilocks piece where we bring down those unnecessary costs, we get those out of the system, we have conversations with people, and invite them to their care solution. They're intelligent and they'll help us make better decisions that aren't necessarily are like almost certainly be less costly. So let's assume that's on the side. For our community, I would say, taking a page out of Jay Van Andel's book, right? When Jay Van Andel started back in 2000, when they are actually 1996, when they were having the conversations about starting the Van Andel Institute. This is before any of this stuff was here. His advisors came to him and said, "Hey, listen, you're going to give a big portion of your estate. Here's what we're going to do. If you really want to impact healthcare for current and future generations, and that's our mission statement at the Institute, is current and future generations. The way we're going to do that is you're going to create a fund, and then we're going to have a group of people, really smart people, who are going to review grants from all over the world, the best, smartest people in the world, and we'll fund those grants all over the world." Jay said, "We're not doing that. We're going to do that here in our community. Our community is going to benefit, but by virtue of our benefit, we're going to share it with the world." So it starts here and goes out. So whatever the vision statement is, it has to start here and go out. And even if it's incrementally, we prove that we can do this one thing between Priority Health and Spectrum and Mercy that no one else can do, and they can learn from that. Our community benefits first, and the rest of the community, and then the rest of the world benefits after that. So it has to come from whatever the vision statement is. It has to start from our community out.
Yeah, and I want to make sure, if we start talking about regulatory and all these things too much, it's going to prevent us from doing anything. But because these are, I don't want to say insurmountable, but very challenging topics. There has been a lot of very meaningful, important collaboration already, and quite honestly, we're all here because the medical mile is here, and the medical mile is here. Individual organizations doing very good work, and collective. Is there as much as there should be? No. Could there be more? I love your idea of, and we have got together to talk about this. We just haven't brought it to the next level of, what is the shared mission or vision statement of, if the three organizations were to do even more together, why and what would that look like, and how does that look in 5 or 10 years? I like the idea. I don't know what the answer is, but I think we can build on what we've done. And again, I think there's always a lot of things that are in the here and now, and sometimes we have to sit down and look about what the future looks like and do that more together.
All right, with that, I think this will conclude this panel. If you join me in thanking our panelists.